Hello there, and welcome to the Sleepy Science Society. Tonight, we're drifting into one of the most remarkable processes that unfolds within you, often without your awareness, transforming damage into wholeness and pain into memory. We're exploring the quiet miracle of healing, a phenomenon so intricate and so beautiful that scientists are still uncovering its secrets after centuries of study. If you find comfort in these gentle journeys through science, I invite you to like this video and subscribe to our channel. It helps others discover this peaceful corner where knowledge meets rest, one sleepy soul at a time. But for now, let your shoulders drop, allow your breathing to slow, and prepare to witness the extraordinary ways your body and mind work to restore themselves. Healing is everywhere. It happens in the thin slice across your finger that closes within days, in the bruised muscle that strengthens after rest, in the fractured bone that knits itself whole again. It occurs in the neural pathways that rewire themselves after trauma, in the emotional wounds that gradually lose their sharp edges, in the grieving heart that learns to hold both sorrow and joy simultaneously. From the smallest capillary to the most complex structures in your brain, your body possesses an ancient wisdom, a cellular memory of how to rebuild what has been broken. This process is not simple. It is not a single event, but rather a carefully choreographed sequence of molecular conversations, cellular migrations, and tissue transformations that span days, weeks, months, and sometimes years. When you cut your skin, billions of cells spring into coordinated action, each type knowing precisely what to do and when to do it, as if following instructions written in a language older than consciousness itself. When you experience psychological trauma, your brain begins the delicate work of reorganizing neural connections, finding new pathways around the injury, creating fresh possibilities for understanding and integration. Tonight, we will journey through the layers of healing, from the immediate rush of platelets to a wound site to the years-long process of scar maturation, from the inflammatory cascade that sounds an alarm throughout your body to the quiet neuroplasticity that allows your mind to recover from the deepest hurts. We will witness how cells communicate across vast microscopic distances, how your body decides what needs to be dismantled and what needs to be preserved, how inflammation serves as both destroyer and creator, how time itself becomes woven into the fabric of recovery. The story of healing is ultimately a story about resilience. It reveals that you are designed not just to exist, but to adapt, to transform, to overcome. Every healed wound carries within it the memory of millions of years of evolution, countless generations of ancestors whose bodies learned to survive injury, whose immune systems developed ever more sophisticated defenses, whose nervous systems discovered how to reorganize after damage. You carry this inheritance in every cell, this biological legacy that turns injuries into opportunity for renewal. As you settle deeper into this exploration, allow yourself to marvel at the fact that healing is happening within you right now, in this very moment. Old cells are being replaced with new ones. Tiny damages are being repaired. Neural connections are being refined and strengthened. Your body is engaged in a constant process of maintenance and restoration, a tireless effort to keep you whole, to keep you functioning, to keep you alive. let us begin with the moment of injury itself, with that first instant when the barrier of your skin is breached and your body's remarkable healing response springs into action. The orchestrated dance of wound healing. Imagine a paper cut, that thin line of separation in the skin that arrives with a brief sting. In that instant, before conscious thought has fully registered what has happened, your body has already initiated a complex cascade of events that will unfold over the coming days and weeks. The wound healing process, when examined closely, reveals itself as one of nature's most elegant solutions to the problem of tissue damage. The first phase, hemostasis, begins within seconds. The word itself comes from the Greek terms for blood and standing, which perfectly describes what needs to happen. The flow of blood must be stopped. When a blood vessel is damaged, the smooth muscle cells in the vessel walls immediately contract, narrowing the channel and reducing blood flow to the area. This vasoconstriction is your body's first line of defense against blood loss. A rapid mechanical response that buys time for more sophisticated mechanisms to engage. Within moments, platelets arrive at the scene. These small disc-shaped cell fragments circulate constantly through your bloodstream, waiting for exactly this moment. When they encounter the damaged endothelial lining of the blood vessel, they undergo a dramatic transformation. They become sticky, adhering to the exposed collagen fibers beneath the vessel's inner surface. They also begin to clump together, forming aggregates that partially plug the hole in the vessel wall. But the platelets do more than simply create a physical barrier. They release a cascade of chemical signals, messenger molecules that amplify the response and recruit additional cellular players to the wound site. Among these signals are factors that activate the coagulation cascade, an intricate series of biochemical reactions that culminates in the formation of fibrin, a protein that polymerizes into long, sticky threads. These fibrin strands weave through the platelet plug, creating a mesh that traps more platelets and red blood cells, solidifying the clot and sealing the wound. This fibrin clot serves multiple purposes. It stops bleeding, certainly, but it also provides a temporary scaffold, a provisional matrix upon which the more permanent repair work can begin. Within this mesh, trapped blood cells and platelets continue releasing growth factors and signaling molecules that will guide the next phases of healing. The clot becomes a construction site, marked off and prepared for the major rebuilding effort that is about to unfold. The hemostatic phase typically lasts for several hours to a few days, depending on the size and severity of the wound. During this time, the wound is at its most vulnerable. The temporary seal holds, but it is fragile. The body works urgently to transition from emergency damage control to the more organized work of repair. And, as hemostasis reaches its conclusion, the second phase is already beginning to overlap with it: inflammation. When people hear the word inflammation, they often think of something negative, something to be avoided or suppressed. Swelling, redness, heat, pain, these seem like problems to be solved. But inflammation is not the enemy. It is, in fact, an absolutely essential component of healing, a controlled demolition and cleaning operation that prepares the wound for reconstruction. The inflammatory phase begins as soon as the injury occurs, but it intensifies once hemostasis is well underway. The blood vessels that initially constricted now dilate, increasing blood flow to the wounded area. This vasodilation is triggered by chemical mediators released from damaged cells and activated platelets. Histamine and serotonin pour into the surrounding tissue, causing the vessel walls to become more permeable, allowing fluid and proteins to leak out of the bloodstream and into the tissue spaces. This leakage is what causes swelling, and while it may be uncomfortable, it serves crucial purposes. The fluid that accumulates in the wound bed carries with it antibodies and complement proteins, components of the immune system that will help fight any bacteria or foreign material that entered the wound. The swelling also increases the distance between cells, making it easier for immune cells to migrate through the tissue and reach the wound site. Within hours of injury, neutrophils arrive in force. These white blood cells are the first responders of the immune system, highly mobile and equipped with an arsenal of antimicrobial weapons. Neutrophils follow chemical gradients toward the wound, responding to signaling molecules called chemokines that are released by damaged cells and platelets. When they reach the site of injury, they begin the work of phagocytosis, literally eating bacteria, dead cells, and debris. Neutrophils are efficient but short-lived. They work intensely for a day or two, clearing the wound of immediate threats, and then they die. Their remains are part of what forms pus when a wound becomes infected. But even in clean wounds, dead neutrophils accumulate, and they too must be cleared away. This is where the second wave of immune cells becomes crucial. Monocytes arrive from the bloodstream within 48 hours and after injury. These larger white blood cells squeeze through the walls of blood vessels and migrate into the wound bed, where they transform into macrophages. The name macrophage means big eater, and these cells live up to their designation. They are the cleanup crew, consuming dead neutrophils, bacteria, and damaged tissue with remarkable efficiency. But macrophages do much more than simply clean. They are coordinators, directors of the healing process. As they work, they release a sophisticated array of growth factors and cytokines, chemical messages that will orchestrate the next phase of healing. They secrete platelet-derived growth factor, which attracts fibroblasts to the wound. They release vascular endothelial growth factor, which stimulates the growth of new blood vessels. They produce transforming growth factor beta, which influences how cells differentiate and how much collagen will be synthesized. Without macrophages, healing cannot proceed normally. Experiments in which macrophage function is blocked show dramatically impaired wound healing. These cells are not simply janitors, they are architects and foremen, essential to the transition from inflammation to the constructive work of tissue regeneration. The inflammatory phase typically peaks around 2 to 3 days after injury and can persist for up to a week in normal wound healing. The wound during this time is red, warm, swollen, and tender, all signs that the body's defenses are actively engaged. The heat comes from increased blood flow. The redness comes from dilated blood vessels near the surface. The swelling comes from accumulated fluid and cells. The pain comes from chemical mediators that stimulate nerve endings, creating a protective response that encourages you to guard the injured area to avoid further damage while the fragile repair work begins. As the inflammatory phase gradually subsides, as the wound bed becomes cleaner, and the immediate threat of infection passes, The body shifts its focus from defense and demolition to the intricate work of building new tissue. The stage is set for proliferation. Building new tissue. The proliferation phase. The proliferative phase of wound healing is where the most dramatic visible changes occur. This is when the wound begins to close, when the gap in the tissue starts to fill, when you can actually see progress from day to day. But beneath the surface, the changes are even more profound. Entirely new structures are being constructed, woven together from cells and proteins in a process that transforms the wound bed from a site of destruction into a foundation for renewed skin. This phase typically begins around 3 to 4 days after injury and can continue for 2 to 3 weeks, though the exact timing varies with the wound's size and the individual's health. 3 major processes characterize proliferation: the growth of granulation tissue, the formation of new blood vessels, and the migration of skin cells to cover the wound surface. Granulation tissue is the temporary tissue that fills in the wound gap before the final scar forms. It gets its name from its appearance. When you look at a healing wound, you sometimes see a bumpy, granular texture, especially if the wound is deep enough to require substantial filling. This tissue is fundamentally different from normal skin. It is exceptionally rich in new blood vessels, which give it a bright pink or red color. It contains a dense population of fibroblasts, cells specialized for producing collagen and other components of the extracellular matrix. And it is organized in a relatively random fashion compared to the highly structured architecture of normal dermis. Fibroblasts are the stars of this phase. These spindle-shaped cells migrate into the wound bed in response to the chemical signals released by macrophages during inflammation. They come from the surrounding dermis, traveling along fibrin strands in the blood clot like workers following scaffolding to a construction site. Once they arrive, they begin producing collagen at a furious rate. Collagen is a protein, a long chain of amino acids folded into a specific three-dimensional structure that gives it remarkable tensile strength. Individual collagen molecules align with each other and cross-link, forming fibrils. These fibrils bundle together into larger fibers. The fibers interweave to create a dense network that provides structural support. In the proliferative phase, however, this collagen is laid down quickly and somewhat haphazardly. The fibers run in many directions, not yet organized into the parallel bundles that give normal skin its strength. This is why healing wounds are initially weaker than undamaged skin, even after they have closed. While fibroblasts are building the collagen matrix, another crucial process unfolds: angiogenesis, the formation of new blood vessels. The wound needs oxygen and nutrients to support all this cellular activity, and the initial blood vessels in the area were damaged by the injury. New vessels must grow to support the new tissue. Angiogenesis begins with the activation of endothelial cells, the cells that line the inside of blood vessels. These cells, stimulated by vascular endothelial growth factor and other signaling molecules, begin to change their behavior. They loosen their connections with neighboring cells and start to sprout, sending out extensions that probe into the wound bed. Following chemical gradients, these sprouts extend toward areas of low oxygen concentration, exactly where new blood vessels are most needed. Behind the leading edge of an endothelial sprout, other endothelial cells divide and migrate, creating a solid cord of cells that extends from the parent vessel into the wound. Eventually, these cords hollow out, forming tubes through which blood can flow. Different sprouts connect with each other, creating loops and networks. Smooth muscle cells and pericytes, cells that provide structural support to blood vessels, are recruited to wrap around these new tubes, stabilizing them and helping to control blood flow. The result is a dense capillary network within the granulation tissue, far denser than in normal skin. This temporary excess of blood vessels ensures that the healing tissue receives abundant oxygen and nutrients during the intensive construction phase. Later, as healing progresses, many of these vessels will regress and disappear, leaving behind a more normalized vascular pattern. While granulation tissue is filling the wound and new blood vessels are forming, the third major process of the proliferative phase is occurring at the wound edges: re-epithelialization. Epithelial cells, specifically keratinocytes, are the cells that make up the outer layer of your skin, the epidermis. When the skin is wounded, the continuity of this protective barrier is broken. Restoring it is a high priority for the healing process. Re-epithelialization can begin as early as 12 hours after injury, though it proceeds slowly at first. Keratinocytes at the wound edge undergo a dramatic transformation. They partially release their connections to neighboring cells and to the basement membrane, the thin layer of extracellular matrix that normally anchors them in place. They change shape, becoming more elongated and developing a front-to-back polarity instead of their usual top-to-bottom orientation. They begin to migrate. These leading-edge keratinocytes crawl across the wound surface, using the provisional matrix of fibrin and early collagen as a substrate. They dissolve their path forward by secreting enzymes that break down proteins, and they lay down new attachment proteins behind them. As they migrate, keratinocytes behind them divide, creating new cells that will fill in the epithelial sheet as it advances across the wound. The epithelial cells migrate from all edges of the wound simultaneously, advancing like an incoming tide. When migrating fronts from opposite edges meet in the middle, a remarkable thing happens. Contact inhibition triggers them to stop moving. The cells receive signals that tell them the wound is closed, and they transition from a migratory state back to a normal epithelial phenotype. They re-establish their connections with each other and begin to rebuild the layered structure of normal epidermis. The process of re-epithelialization can take anywhere from a few days for a small wound to several weeks for a larger one. In shallow wounds that only damage the epidermis, epithelial cells can also migrate up from hair follicles and sweat glands, which extend deep into the dermis and survive shallow injuries. This is why superficial abrasions often heal quickly with minimal scarring. They have multiple sources of new epithelial cells. As the proliferative phase draws to a close, the wound has been transformed. The gap has been filled with granulation tissue. New blood vessels perfuse this tissue, bringing oxygen and nutrients. A new layer of epidermis has covered the surface, restoring the protective barrier. But the wound is far from finished healing. The tissue that has been created is temporary, a rough draft that now needs to be refined, reorganized, and strengthened. This is the work of the final phase: maturation and remodeling. Maturation and remodeling. The maturation phase of wound healing is the longest and, in many ways, the most subtle. While the dramatic changes of proliferation capture attention, you can see a wound closing, watch new pink tissue appear. The work of maturation happens more quietly, over months and even years. Yet this phase is crucial. It is what transforms the fragile, provisional tissue of the proliferative phase into a stable, functional scar. Maturation typically begins around 3 weeks after injury, though there is substantial overlap with the proliferative phase. The transition is not a clean switch, but a gradual shift in the balance of activities. Less new collagen is produced. More old collagen is degraded and replaced. The focus moves from construction to refinement, from quantity to quality, from filling space to optimizing structure. Collagen remodeling is the central process of this phase. During proliferation, fibroblasts deposited collagen rapidly, and the resulting network is disorganized. Collagen fibers run in multiple directions, cross-linking where they happen to meet. This random organization provides some strength, but nothing like the tensile strength of normal skin, where collagen fibers align in parallel bundles oriented to resist the specific stresses that skin experiences. Remodeling begins with degradation. Specialized enzymes called matrix metalloproteinases break down the disorganized collagen. These enzymes are produced by fibroblasts, macrophages, and other cells in the wound. They clip the collagen molecules into fragments that can be cleared away. At the same time, fibroblasts continue to produce new collagen, but at a much slower rate than during proliferation. This new collagen is laid down more carefully, more deliberately. Over time, through cycles of degradation and synthesis, the collagen network reorganizes. Fibers begin to align along lines of mechanical stress. They thicken as more collagen molecules bundle together. Crosslinks form between adjacent fibers, creating a more integrated, more stable structure. The process is gradual, incremental, like the slow work of an editor refining a manuscript, removing unnecessary words, clarifying meaning, strengthening the flow. As collagen matures, it also changes chemically. Initially, collagen molecules are connected by relatively weak bonds. Over time, these are replaced by stronger crosslinks, covalent bonds that tie molecules together more permanently. This cross-linking increases the tensile strength of the scar tissue progressively over many months. The maturation phase also involves a significant decrease in cellularity and vascularity. During proliferation, the wound was packed with cells, fibroblasts, macrophages, endothelial cells, and others. The tissue was rich in blood vessels, far more than normal skin. As maturation proceeds, many of these cells undergo apoptosis, programmed cell death. They are no longer needed, and their removal helps the tissue become more streamlined, more efficient. Similarly, many of the blood vessels that formed during angiogenesis regress. The excess capillaries that supported the intensive metabolic activity of proliferation are no longer necessary. The remaining vessels mature, acquiring more structural support from smooth muscle cells and pericytes, becoming more stable and less leaky. The tissue gradually fades from the bright red or pink of granulation tissue to a paler color as vascularity decreases. Some fibroblasts in the healing wound differentiate into myofibroblasts, specialized cells that contain contractile proteins similar to those found in smooth muscle cells. Myofibroblasts pull on the collagen fibers to which they are attached, generating tension that causes wound contraction. This contraction reduces the size of the wound, pulling the edges closer together. In large wounds, contraction can account for a substantial portion of wound closure, sometimes reducing the wound area by 70 to 80%. However, excessive contraction can cause problems, especially in wounds near joints, where it can lead to contractures that limit range of motion. The remodeling process continues for a very long time, much longer than most people realize. Significant changes occur over the first several months, but subtle modifications continue for up to 2 years or more. Even after 2 years, the scar tissue will not be identical to the original skin. It will have different properties, different organization, different strength. One of the most important facts about scar tissue is that it never fully regains the strength of unwounded skin. Even after complete maturation, scar tissue typically has only about 75 to 80% of the tensile strength of normal skin. This is because the collagen organization, despite all the remodeling, never perfectly replicates the highly ordered architecture that develops during normal skin formation. The parallel bundles are less perfect. The cross-linking is different, and the integration with surrounding structures is never quite seamless. Scars also lack certain features of normal skin. They do not contain hair follicles or sweat glands. These structures destroyed during the injury are not regenerated during healing. The pigmentation of scars is often different from surrounding skin, sometimes lighter, sometimes darker, because the melanocytes that produce skin pigment are also not fully restored. The texture of scar tissue may feel smoother or rougher than normal skin, depending on how the collagen has organized. The appearance of a scar changes substantially over time. Initially, a fresh scar may be red or purple, raised above the surrounding skin, and somewhat firm to the touch. Over months, the color fades as blood vessels regress. The scar may flatten as remodeling progresses and contractile forces balance out. It may soften as the collagen network becomes more organized and less densely packed. By 1 to 2 years post-injury, most scars have reached their final appearance, though small changes may continue for longer. Understanding that healing takes time, that the maturation phase is measured in months and years rather than days and weeks, can be important for managing expectations. A scar that looks prominent at 1 month after injury will often improve significantly by 6 months and may improve further by 1 year. The body is working constantly, even when the changes are not immediately visible, to refine and optimize the repair. In some cases, the healing process goes too far, producing excessive scar tissue. Hypertrophic scars remain confined to the boundaries of the original wound but are raised, thickened, and may be itchy or uncomfortable. Keloids go even further, extending beyond the wound boundaries into surrounding normal skin. Both conditions result from dysregulation of collagen synthesis and degradation, with production outpacing breakdown. The reasons why some individuals are prone to excessive scarring while others heal with minimal marks are not fully understood, though genetics clearly plays a role, as does the location of the wound and the degree of tension on the healing tissue. Understanding these phases of wound healing, hemostasis, inflammation, proliferation, and maturation, provides insight into how remarkable and complex the process truly is. But beneath these macroscopic phases, an even deeper level of coordination exists. The molecular symphony of growth factors and cellular signals that orchestrates every step. The molecular symphony. If you could zoom into the molecular level of a healing wound, you would witness an astonishing ballet of chemical communication. Cells do not act in isolation, following predetermined programs. Instead, they constantly send and receive signals, chemical messages that tell them what to do, when to do it, and when to stop. This molecular conversation is essential to coordinated healing. Without it, the process would descend into chaos. Growth factors are among the most important signaling molecules in wound healing. These are proteins secreted by cells that bind to receptors on target cells, triggering specific responses. Different growth factors have different effects, and the same growth factor can cause different cells to respond in different ways. The timing and concentration of growth factors are carefully controlled, creating a dynamic signaling environment that changes as healing progresses. Platelet-derived growth factor, or PDGF, is one of the first growth factors to appear at a wound site. It is released from the alpha granules of platelets when they degranulate during clot formation. PDGF has multiple effects. It is chemotactic for neutrophils, macrophages, and fibroblasts, meaning it attracts these cells to the wound. It also stimulates fibroblasts to proliferate and produce collagen. In essence, PDGF jumpstarts the healing response, calling in the cellular workforce that will do the actual repair work. Transforming growth factor beta, or TGF-beta, is another crucial player. This growth factor is also released from platelets, but it is also produced by macrophages, fibroblasts, and other cells as healing proceeds. TGF-beta has complex effects that vary depending on the context. It stimulates fibroblasts to produce collagen and other matrix proteins. It promotes the differentiation of fibroblasts into myofibroblasts, which contribute to wound contraction. It can also have anti-inflammatory effects, helping to resolve inflammation as the need for immune activity decreases. However, excessive TGF-beta signaling is associated with fibrosis and scarring, making it a double-edged sword in the healing process. Vascular endothelial growth factor, or VEGF, is essential for angiogenesis. Produced by macrophages, fibroblasts, and keratinocytes in response to low oxygen levels, VEGF stimulates endothelial cells to proliferate, migrate, and form new blood vessels. The gradient of VEGF concentration guides the sprouting of capillaries toward areas that need increased blood supply. As oxygen levels normalize and healing tissue becomes well vascularized, VEGF production decreases and the angiogenic stimulus wanes. Fibroblast growth factors, or FGFs, are a family of proteins with diverse effects on wound healing. Basic FGF, or BFGF, stimulates angiogenesis, promotes fibroblast proliferation, and enhances keratinocyte migration during re-epithelialization. Different members of the FGF family are active at different phases of healing, contributing to the coordinated progression through the healing stages. Epidermal growth factor, or EGF, specifically promotes the proliferation and migration of epithelial cells. It is found in high concentrations in saliva, which may be one reason why oral wounds tend to heal quickly. EGF binds to receptors on keratinocytes, triggering signaling cascades that promote cell division and movement, accelerating the re-epithelialization process. These growth factors do not work in isolation. They interact with each other, sometimes synergistically, sometimes antagonistically. A cell may receive multiple signals simultaneously, and the integrated response depends on the combination and sequence of signals. This allows for fine control, for nuanced responses to complex situations. Beyond growth factors, cytokines play crucial roles in wound healing. While the terms are sometimes used interchangeably, cytokines generally refer to signaling molecules involved in immune and inflammatory responses, while growth factors primarily regulate cell growth and differentiation. In practice, there is significant overlap in function. Interleukin-1, or IL-1, is a pro-inflammatory cytokine produced by macrophages and other cells during the inflammatory phase. It enhances the inflammatory response, promoting the recruitment of additional immune cells and increasing the production of other inflammatory mediators. It also stimulates fibroblasts and endothelial cells, contributing to proliferation and angiogenesis. Tumor necrosis factor alpha, or TNF-alpha, is another pro-inflammatory cytokine with complex effects. In the early stages of healing, it helps coordinate the inflammatory response and promotes angiogenesis. However, chronic or excessive TNF-alpha can impair healing, contributing to the formation of chronic wounds. This illustrates an important principle. The same signaling molecules that promote healing in appropriate amounts and at appropriate times can become harmful if dysregulated. Interleukin-10, or IL-10, is an anti-inflammatory cytokine that helps resolve inflammation. As the inflammatory phase progresses, the balance shifts toward anti-inflammatory signals like IL-10, which suppress the production of pro-inflammatory cytokines and help transition the wound environment toward proliferation and tissue construction. Without adequate anti-inflammatory signals, inflammation can become chronic, preventing the progression to subsequent healing phases. Chemokines are signaling molecules that specifically guide cell migration. They create concentration gradients that cells can detect and follow. Different chemokines attract different cell types. IL-8, for example, is a powerful chemoattractant for neutrophils, helping guide these cells from the bloodstream to the wound site. Other chemokines attract monocytes, lymphocytes, and fibroblasts, ensuring that the right cells arrive at the right time. The extracellular matrix itself participates in signaling, as fibroblasts produce collagen, fibronectin, and other matrix proteins. These molecules do more than provide structural support. They also contain binding sites for growth factors and other signaling molecules, essentially storing these signals in the matrix and releasing them when appropriate. Some matrix proteins, when broken down during remodeling, release fragments that have their own signaling activity, adding another layer of complexity to the regulatory network. Cell surface receptors translate these chemical signals into cellular responses. When a growth factor binds to its receptor, it triggers a cascade of intracellular events. Proteins are phosphorylated, activating them. Signaling molecules move to the nucleus and activate specific genes. The cell begins producing new proteins, alters its metabolism, changes its behavior. A single growth factor binding event can trigger hundreds or thousands of downstream changes, amplifying the initial signal and translating it into coordinated cellular action. This molecular symphony is not conducted by a single maestro. There is no central controller directing the process. Instead, it is an emergent property of the system, arising from countless local interactions between cells and signaling molecules. Each cell responds to the signals it receives, modifies its behavior accordingly, and in turn produces signals that affect its neighbors. The overall pattern of healing emerges from this distributed network of communication. When you consider the complexity of this molecular orchestration, the dozens of growth factors and cytokines, the hundreds of cell surface receptors, the thousands of intracellular signaling proteins, all interacting in a dynamic, changing environment, it becomes clear that healing is not a simple linear process. It is a robust, adaptive system that can respond to changing conditions, compensate for disruptions, and generally achieve a good outcome despite variations in the starting conditions. Yet this very complexity also creates vulnerabilities. Disruptions at the molecular level can impair healing, leading to chronic wounds or excessive scarring. Understanding what can go wrong illuminates both how remarkable normal healing is and why some wounds struggle to heal. When healing goes awry, not all wounds heal smoothly. While the majority of injuries progress through the orderly sequence of hemostasis, inflammation, proliferation, and maturation, some wounds stall, some become stuck in a prolonged inflammatory state, and some produce excessive scar tissue that causes more problems than the original injury. Understanding these failures of healing provides insight into the delicate balance required for successful repair. Chronic wounds are defined as wounds that fail to heal within 4 weeks or that fail to proceed through the normal sequence of healing phases. These wounds represent a significant medical problem, affecting millions of people worldwide and costing healthcare systems billions of dollars annually. The burden is increasing as populations age and as conditions like diabetes become more prevalent. Several factors can cause a wound to become chronic. Infection is one of the most common. When bacteria colonize a wound in sufficient numbers, they can overwhelm the immune response. Many chronic wounds harbor bacteria in the form of biofilms, complex communities of bacteria embedded in a self-produced matrix of polysaccharides and proteins. Biofilms are remarkably resistant to both antibiotics and immune attack. They create a protected microenvironment, where bacteria can persist indefinitely, sustaining inflammation and preventing the wound from progressing to proliferation. Inadequate blood supply is another major cause of chronic wounds. Tissue needs oxygen and nutrients to heal, and these are delivered by blood vessels. In conditions like peripheral arterial disease, where arteries are narrowed by atherosclerosis, blood flow to the extremities is reduced. Wounds in poorly perfused tissue struggle to heal because cells cannot obtain enough oxygen to support the energy-intensive processes of proliferation and matrix synthesis. Venous insufficiency, where blood pools in the legs due to faulty valves and veins, can also impair healing by creating tissue edema and reducing oxygen delivery. Diabetes disrupts healing through multiple mechanisms. High blood glucose levels damage blood vessels, reducing perfusion. They impair immune cell function, making diabetic individuals more susceptible to infection and less able to clear bacteria from wounds. Diabetes also alters growth factor signaling and cytokine production, disrupting the molecular communication essential to coordinated healing. Diabetic foot ulcers are particularly problematic, combining poor blood supply, neuropathy that prevents recognition of injury, and increased infection risk. These ulcers can become chronic, lasting for months or years, and in severe cases can lead to amputation. Aging affects healing in multiple ways. Older skin is thinner and more fragile, making it easier to injure. The inflammatory response in older individuals is often dysregulated, with inflammation persisting longer than necessary. The proliferative response is slower, with reduced fibroblast activity and decreased collagen production. Angiogenesis is impaired, and re-epithelialization takes longer. While most wounds in healthy older adults will eventually heal, the process is slower and more vulnerable to complications. Malnutrition impairs healing because the body lacks the raw materials needed to build new tissue. Protein deficiency is particularly problematic since collagen is a protein and requires adequate amino acid supply. Vitamin C deficiency causes scurvy, a condition characterized by impaired collagen synthesis and poor wound healing. Vitamin A deficiency impairs epithelialization and reduces immune function. Zinc deficiency slows healing and increases infection risk. Even in developed countries, malnutrition can be an issue, particularly in hospitalized patients, the elderly, and those with chronic diseases. Medications can also affect healing. Corticosteroids, widely used for their anti-inflammatory effects, suppress the immune response and can significantly impair healing, particularly if used at high doses during the early phases when inflammation is necessary. Chemotherapy drugs, which target rapidly dividing cells, can interfere with proliferation phase processes. Some drugs affect platelet function or blood clotting, potentially increasing bleeding risk or altering the initial hemostatic response. At the opposite extreme from chronic wounds that fail to heal are conditions where the healing response is excessive. Hypertrophic scars and keloids both result from overproduction of collagen, but they differ in important ways. Hypertrophic scars are raised and thickened but remain within the boundaries of the original wound. They typically develop within weeks after injury, may improve over months to years and are caused by excessive collagen production that eventually resolves. Keloids extend beyond the wound boundaries into normal surrounding skin. They can continue to grow for months or years after the initial injury, do not regress spontaneously, and often recur even after surgical removal. The underlying cause of keloid formation remains incompletely understood, but it clearly involves dysregulation of the signals that normally terminate the proliferative phase and control collagen synthesis. Genetic factors are important. Keloids are more common in individuals with darker skin tones and tend to run in families. Certain body locations, particularly the chest, shoulders, and earlobes, are more prone to keloid formation. Tension on the healing wound also plays a role, with wounds subjected to greater mechanical stress more likely to form excessive scars. The cellular and molecular events in keloids differ from normal scars. Fibroblasts in keloids are more active and more responsive to growth factors like TGF-beta. They produce collagen at a higher rate and for a longer duration. The balance between matrix metalloproteinases, which break down collagen, and their inhibitors is shifted toward less degradation. Inflammation persists longer, with continued presence of immune cells and inflammatory mediators that keep fibroblasts activated. Treatment of keloids is challenging. Surgical removal alone usually leads to recurrence because the underlying tendency toward excessive scarring remains. Combining surgery with other treatments, corticosteroid injections, pressure therapy, radiation, or silicone gel sheeting improves outcomes but does not guarantee success. Prevention is more effective than treatment, which means identifying individuals at high risk and taking steps to minimize injury to the skin when possible. Contractures represent another form of problematic healing. When wounds heal by contraction, myofibroblasts pull the edges together, which is generally beneficial. However, excessive contraction can cause problems, particularly in wounds that cross joints or in large burns. A contracture can limit range of motion, causing functional impairment. In severe cases, contractures can cause disfigurement. Treatment requires releasing the contracted tissue, often surgically, and may involve skin grafts or other reconstructive procedures to provide enough tissue to allow normal movement. Understanding what can go wrong with healing underscores how remarkable it is when healing goes right. The process requires precise coordination of numerous factors: adequate blood supply, appropriate immune response, proper growth factor signaling, sufficient nutrition, and absence of overwhelming infection. When all these factors align, the body can repair even substantial injuries. When they do not, healing stalls or becomes pathological. Yet healing is not limited to physical wounds. The brain, too, has remarkable capacities for repair and adaptation, particularly in response to psychological trauma. The mechanisms differ from wound healing in many ways, but the fundamental principle remains the same. The body possesses inherent abilities to restore function after damage. The brain's remarkable healing powers. When we speak of healing, we usually think first of physical injuries, cuts, bruises, broken bones. But perhaps the most remarkable form of healing occurs in the brain, where psychological trauma can be processed, where damaged neural circuits can reorganize, where emotional wounds that once seemed permanent can gradually lose their power. Understanding how the brain heals from trauma reveals principles of plasticity and adaptation that rival even the complex choreography of physical wound healing. The brain's ability to change and adapt throughout life is called neuroplasticity. For much of the 20th century, neuroscientists believed that the adult brain was essentially fixed, that neurons did not regenerate, and that the connections between neurons were stable and unchanging after a critical period in early development. This view has been thoroughly overturned. The brain is now understood to be dynamic, constantly reshaping itself in response to experience, capable of forming new connections, strengthening or weakening existing ones, and even generating new neurons in certain regions. This plasticity is what makes recovery from brain injury possible. When a stroke damages part of the brain, surviving neurons can sometimes take over the functions that were lost. When trauma creates pathological patterns of neural activity, therapy can help establish new, healthier patterns. The mechanisms that enable learning and memory, the formation and modification of synapses, the strengthening of frequently used pathways, the pruning of unused connections. These same mechanisms can support healing. To understand how trauma affects the brain and how healing occurs, we need to look at specific brain structures involved in stress response and emotional processing. 3 regions are particularly important: the amygdala, the hippocampus, and the prefrontal cortex. The amygdala is an almond-shaped structure deep in the temporal lobe, one in each hemisphere. It is central to processing emotions, particularly fear and anxiety. When you encounter something threatening, the amygdala activates rapidly, often before you are consciously aware of the danger. It triggers the fight or flight response. Your heart rate increases, your breathing quickens, stress hormones flood your bloodstream, your attention narrows to focus on the threat. This response is adaptive. It prepares you to respond to danger quickly and effectively. However, trauma can dysregulate the amygdala. After experiencing severe or repeated traumatic events, the amygdala can become hyperactive, responding to situations that are not actually threatening as if they were. This leads to heightened anxiety, hypervigilance, and exaggerated startle responses. The individual feels constantly on edge, unable to relax, as if danger lurks around every corner. This hyperactivity of the amygdala is a core feature of post-traumatic stress disorder. The hippocampus is adjacent to the amygdala and plays crucial roles in memory formation and spatial navigation. It is essential for forming new explicit memories of facts and events that can be consciously recalled. The hippocampus is also involved in contextualizing experiences, in distinguishing whether a current situation is similar to or different from past events. Trauma and chronic stress can damage the hippocampus. Studies have shown that individuals with PTSD often have reduced hippocampal volume compared to healthy controls. Stress hormones, particularly cortisol, are toxic to hippocampal neurons when present at high concentrations for extended periods. This damage impairs memory function and contributes to one of the characteristic symptoms of PTSD: fragmented, disorganized memories of the traumatic event itself. The compromised hippocampus also struggles to contextualize current experiences properly. It has difficulty determining whether a situation is genuinely dangerous or merely reminiscent of past trauma. This contributes to inappropriate fear responses. The individual reacts to safe situations as if they were dangerous because the brain cannot properly distinguish between then and now. The prefrontal cortex, particularly the medial prefrontal cortex and the anterior cingulate cortex, is involved in executive functions, planning, decision-making, impulse control, and in emotion regulation. When functioning properly, the prefrontal cortex can exert top-down control over the amygdala, dampening emotional responses and allowing rational evaluation of situations. It is what enables you to recognize that a sudden loud noise is just a door slamming, not a threat, and to calm yourself down after the initial startle response. Trauma and chronic stress can impair prefrontal cortex function. The region becomes underactive, less able to regulate the overactive amygdala. This creates a vicious cycle. The amygdala fires excessively, triggering strong emotional responses, but the prefrontal cortex cannot effectively modulate these responses, so the emotions persist and intensify. The individual feels out of control, unable to manage feelings of fear, anger, or helplessness. Imaging studies of people with PTSD show these patterns clearly. Increased activity in the amygdala, decreased hippocampal volume, and reduced activity in the prefrontal cortex. The brain has been reorganized by trauma, settling into patterns of activity that made sense during the traumatic event. Hypervigilance to threats, rapid emotional responses, reduced deliberative thinking. But that cause problems in everyday life when the danger has passed. Yet the same neuroplasticity that allows trauma to reshape the brain also provides the mechanism for healing. The brain can be changed by experience, and therapeutic experiences can foster beneficial changes. This is where evidence-based therapies for trauma become crucial. The goal of trauma therapy is not to erase traumatic memories. That is neither possible nor necessarily desirable, but to change how those memories are processed and stored, to reduce their emotional intensity, and to help the individual develop more adaptive responses. Several therapeutic approaches leverage the brain's plasticity to achieve these goals. Cognitive behavioral therapy works by helping individuals identify and modify unhelpful patterns of thinking and behavior. In the context of trauma, CBT often involves cognitive restructuring, examining beliefs that developed in response to trauma, such as, "The world is completely unsafe," or "I am powerless," and evaluating whether these beliefs are accurate or helpful. By repeatedly practicing more balanced, realistic thinking patterns, the individual strengthens neural pathways that support healthier cognitions. Over time, these new patterns can become more automatic, replacing the trauma-related thought patterns. Exposure therapy, often a component of CBT for trauma, involves gradually and safely confronting trauma-related memories, feelings, and situations that have been avoided. The principle is that avoidance maintains fear. By never encountering the feared stimulus, the individual never learns that it is not actually dangerous. Through repeated, controlled exposure, the brain can learn new associations. The traumatic memory becomes paired with the experience of safety rather than with overwhelming fear. The amygdala's response gradually habituates, becoming less intense with each exposure. At the same time, the prefrontal cortex becomes more engaged, better able to exert regulatory control. Eye movement. Desensitization and reprocessing, or EMDR, is a specific therapy designed for trauma that has gained substantial empirical support. During EMDR sessions, the individual recalls traumatic memories while simultaneously engaging in bilateral stimulation, typically following the therapist's finger moving back and forth with their eyes, though tapping or auditory tones can also be used. The exact mechanism by which EMDR works remains debated, but several theories have been proposed. One theory suggests that bilateral stimulation engages both hemispheres of the brain, facilitating integration of traumatic memories that may be stored primarily in the emotional right hemisphere with the more verbal, analytical left hemisphere. This integration allows the memories to be processed more completely, reducing their emotional charge. Another theory proposes that the eye movements engage working memory, which has limited capacity. By taxing working memory during recall of the traumatic event, the vividness and emotional intensity of the memory are reduced. Neuroimaging studies show that EMDR changes brain activity patterns. After successful EMDR treatment, the hyperactivity of the amygdala decreases and activity in the prefrontal cortex increases. The traumatic memory becomes more like an ordinary memory. It can be recalled without triggering overwhelming emotion. The individual can think about what happened without being pulled back into the experience as if it were happening again. These therapies work because they leverage neuroplasticity. Each time the individual engages in therapeutic exposure, practices new coping skills, or processes traumatic memories in a safe environment, neural connections are being modified. Synapses that support trauma-related fear responses weaken through lack of reinforcement. Synapses that support more adaptive responses strengthen through repeated activation. Over weeks and months of therapy, these incremental changes accumulate, shifting the overall pattern of brain activity toward healthier configurations. The process takes time, patience, and often considerable emotional courage. Healing from psychological trauma is not a linear process. There are setbacks, difficult sessions, moments when progress seems impossible. But the fundamental capacity for change is there, built into the very structure of the brain. The same plasticity that allows you to learn a new language, master a musical instrument, or memorize a route through a city also allows you to recover from trauma, to build new neural pathways that bypass damaged circuits, to reorganize emotional responses into patterns that serve life rather than fear. Understanding that trauma changes the brain in observable, measurable ways can be liberating. It means that the symptoms are not a sign of weakness or personal failing, but rather an understandable response to abnormal experiences. And understanding that the brain can change again, that plasticity continues throughout life, provides hope that recovery is possible. The brain that was shaped by trauma can be reshaped by healing experiences. Emotional healing and recovery. While neuroplasticity provides the fundamental mechanism for brain healing, the actual process of emotional recovery involves more than just neural reorganization. It requires creating safe environments, establishing new patterns of thinking and feeling, processing difficult emotions, and often fundamentally revising one's understanding of self and world. Emotional healing is multifaceted, engaging cognitive, emotional, behavioral, and social dimensions simultaneously. One of the first requirements for emotional healing is safety. The brain cannot fully engage in the work of processing trauma while it remains in survival mode. When an individual still faces ongoing threat, whether physical danger, an abusive relationship, or a chaotic environment, the stress response system remains activated. The amygdala stays vigilant. The body stays flooded with stress hormones, and the prefrontal cortex remains partially offline. Healing requires establishing conditions where the threat is genuinely reduced or absent, where the nervous system can begin to down-regulate, where the individual can shift from survival to recovery. This is why trauma-informed approaches emphasize creating safety first. In therapy, this means establishing a therapeutic relationship characterized by trust, consistency, and respect. It means helping the individual develop skills for managing overwhelming emotions before diving into processing traumatic memories. It means recognizing that what feels safe varies from person to person and checking in regularly about whether the pace and content of therapy feel manageable. Once sufficient safety has been established, the work of processing traumatic memories can begin. Traumatic memories are often stored differently from ordinary memories. They may be fragmented, lacking a clear narrative structure. They may be intensely sensory, dominated by images, sounds, smells, physical sensations, with little verbal content. They may intrude involuntarily, triggered by reminders that may not even be consciously recognized. And they carry intense emotional charge, capable of overwhelming the individual when activated. Processing these memories involves several goals. One is to create a coherent narrative, to take the fragmented pieces and organize them into a story that has a beginning, middle, and end. This narrative construction engages the left hemisphere's verbal, analytical capacities, helping to integrate memories that may have been stored primarily as wordless right hemisphere emotional experiences. Having a coherent narrative allows the individual to make sense of what happened, to understand the sequence of events, to locate the trauma in the past rather than experiencing it as an ongoing present reality. Another goal is to reduce the emotional intensity associated with the memories. This does not mean eliminating all feeling. The events were significant and deserve emotional response, but rather reducing the overwhelming, dysregulating intensity that characterizes unprocessed trauma. Through techniques like graduated exposure, where memories are recalled while maintaining a sense of safety and control, the brain learns that remembering the trauma is not the same as re-experiencing it. The pairing of memory recall with present safety gradually weakens the association between memory and overwhelming fear. A third goal is to identify and modify the beliefs that developed in response to trauma. Traumatic experiences often lead to global, negative beliefs about self, others, and the world. I am powerless. No one can be trusted. The world is completely dangerous. I am fundamentally damaged. These beliefs made sense in the context of the trauma, but they may not accurately reflect current reality, and they can severely constrain how the individual lives. Cognitive restructuring helps examine these beliefs, test them against evidence, and develop more nuanced, balanced perspectives. This cognitive work changes the brain in measurable ways. Brain imaging studies show that successful cognitive therapy increases activity in the prefrontal cortex, strengthening the neural circuits involved in rational evaluation and emotional regulation. It also reduces activity in the amygdala, dampening automatic fear responses. The brain is learning new patterns, practicing different ways of interpreting experience, and these patterns become more entrenched with repetition. Mindfulness-based approaches offer another road to healing, one that focuses less on analyzing and restructuring thoughts and more on changing one's relationship to thoughts and emotions. Mindfulness involves paying attention to present moment experience with an attitude of openness and non-judgment. Rather than trying to change the content of thoughts, mindfulness teaches observing thoughts as mental events that arise and pass, without necessarily believing them or acting on them. For individuals with trauma histories, mindfulness can be particularly valuable. It helps create distance from intrusive thoughts and overwhelming emotions. Instead of being swept away by a memory or a feeling, the individual can observe, "I am having a memory of the trauma," or "I am feeling fear right now." This observational stance engages the prefrontal cortex and reduces identification with the content of experience. Over time, this practice can reduce the frequency and intensity of trauma symptoms. Research shows that regular mindfulness practice causes measurable changes in brain structure and function. It increases gray matter density in the prefrontal cortex and hippocampus. It reduces activity in the amygdala. It strengthens connectivity between regions involved in attention and emotion regulation. These changes support greater resilience, more stable mood, and improved ability to manage stress. Somatic approaches to trauma therapy focus on the body rather than primarily on thoughts or memories. Trauma is not just a psychological phenomenon, it is held in the body. Traumatic memories are often intensely physical. The racing heart, the tension in muscles, the sensation of being frozen or unable to move. Somatic therapies like sensory motor psychotherapy help individuals become more aware of these bodily sensations and learn to work with them directly. The rationale is that traumatic memories are stored not just as mental content, but as patterns of autonomic nervous system activation and muscular tension. By bringing awareness to these physical patterns, gently exploring them, and allowing them to shift and release, the individual can process trauma at a somatic level. This can be particularly helpful for memories that are not fully accessible to verbal processing, that remain primarily as bodily experiences. Social connection is another crucial element of emotional healing. Trauma often leads to isolation. The individual may withdraw from others out of mistrust, shame, or the belief that others cannot understand. Yet humans are fundamentally social creatures, and connection with others is deeply healing. Supportive relationships provide multiple benefits. They offer practical help and emotional comfort. They counteract beliefs about being alone or unworthy of care. They provide opportunities to practice trust, and they activate neural systems involved in safety and bonding. The neurobiology of social connection involves the release of oxytocin, sometimes called the bonding hormone. Oxytocin reduces activity in the amygdala, promoting feelings of calm and safety. It enhances social cognition, making it easier to read others' emotions and intentions accurately. It facilitates trust and cooperation. Positive social interactions, whether with friends, family, support groups, or therapists, stimulate oxytocin release and engage neural circuits that counteract the effects of trauma. Group therapy can be particularly powerful for trauma survivors. Being with others who have had similar experiences reduces the sense of isolation and abnormality. Hearing others' stories and sharing one's own creates validation and mutual support. Witnessing others' recovery journey provides hope and models for one's own healing. The group becomes a safe community where connection can be practiced and where the social engagement system can begin to come back online. Healing from emotional trauma is not about returning to exactly who you were before the trauma. Trauma changes people, and some of those changes may be permanent. But healing is about integrating the trauma into one's life story, about building new capacities for joy and connection alongside the memories of suffering, about moving from being a victim of the past to being an agent in the present. It is about reclaiming the ability to live fully, even while carrying the knowledge of what has been endured. The timeline for emotional healing varies dramatically from person to person and depends on many factors. The nature and severity of the trauma, the age at which it occurred, the availability of support, the presence of additional stressors, access to effective treatment. Some individuals recover relatively quickly, others struggle for years. There is no right timeline, no schedule that healing should follow. What matters is the direction of change, the gradual accumulation of better days, the slowly increasing capacity to engage with life. Throughout this process, the brain is working, constantly adapting, forming new connections, weakening old ones, discovering alternative pathways. The plasticity that makes trauma's impact possible also makes recovery possible. And the same nervous system that learned to respond to the world with fear and hypervigilance can learn to respond with greater calm and resilience. The body-mind connection in healing. Increasingly, science recognizes that the distinction between physical and emotional healing is somewhat artificial. The body and mind are not separate systems but deeply interconnected aspects of a single organism. What affects the brain affects the body, and what affects the body affects the brain. This bidirectional relationship is particularly evident in the healing process, where psychological factors influence physical recovery, and physical factors influence psychological well-being. The stress response system provides a clear example of body-mind integration. When you perceive a threat, whether that threat is physical or psychological, the hypothalamus activates the sympathetic nervous system and triggers the release of stress hormones, particularly cortisol and adrenaline. These hormones prepare the body for action. Heart rate increases, blood pressure rises, blood flow shifts toward muscles, glucose is mobilized for energy, and immune function is temporarily enhanced. This response is adaptive in the short term. If you need to flee from danger or fight off an attacker, these physiological changes improve your chances of survival. But the stress response was designed for acute threats, brief, intense situations followed by recovery. Modern life often presents chronic stressors, ongoing work pressure, financial strain, relationship conflicts, discrimination, or the aftermath of trauma. When the stress response is activated repeatedly or continuously, it becomes harmful. Chronic stress keeps cortisol levels elevated. Over time, this has numerous negative effects. It suppresses the immune system, making you more vulnerable to infections and slowing wound healing. It contributes to cardiovascular disease by maintaining elevated blood pressure and promoting inflammation in blood vessels. It impairs memory and cognitive function by damaging the hippocampus. It increases the risk of anxiety and depression. It disrupts sleep, digestion, and reproductive function. The impact of chronic stress on wound healing has been demonstrated in multiple studies. In one experiment, researchers gave small, standardized wounds to caregivers of dementia patients, a group experiencing chronic stress, and to matched controls. The wounds in the caregivers took significantly longer to heal, and their inflammatory markers remained elevated longer. Other studies have shown that students under the stress of examinations heal wounds more slowly than during less stressful periods. Marital conflict and psychological stress have been shown to slow wound healing and increase inflammation. The mechanism appears to involve multiple pathways. Stress hormones directly affect immune cell function, altering the production of cytokines and growth factors needed for healing. Stress increases systemic inflammation, which can become counterproductive when it is chronic rather than acute. Stress may reduce blood flow to peripheral tissues, limiting the delivery of oxygen and nutrients to wounds. It may also affect behaviors that support healing, such as sleep, nutrition, and self-care. The reverse is also true. Physical illness and pain affect psychological well-being. Living with chronic pain can lead to depression and anxiety. Dealing with the limitations imposed by physical injury or illness can undermine sense of self and purpose. The stress of managing medical treatments and healthcare systems takes a psychological toll. Physical and emotional healing are intertwined, each influencing the other in complex feedback loops. Inflammation provides another window into the body-mind connection. As we discussed earlier, inflammation is essential to wound healing. But inflammation is also increasingly recognized as playing a role in many psychiatric conditions. Depression, in particular, is associated with elevated markers of systemic inflammation. Some researchers propose that depression, at least in some cases, may be an inflammatory condition as much as a purely psychological one. The relationship between inflammation and mood may work in both directions. Psychological stress can increase inflammation through activation of the sympathetic nervous system and stress hormone pathways. Inflammation, in turn, affects the brain, altering neurotransmitter function and neural circuit activity in ways that promote symptoms of depression and anxiety. This creates potential vicious cycles where stress increases inflammation. Inflammation worsens mood, low mood increases stress, and so on. This understanding opens new possibilities for intervention. If inflammation contributes to psychological symptoms, then anti-inflammatory strategies might provide therapeutic benefit. Exercise, for example, has anti-inflammatory effects and is increasingly recognized as an effective treatment for depression. Omega-3 fatty acids, found in fish oil, have anti-inflammatory properties and show some promise as adjunct treatments for mood disorders. Mindfulness and other stress reduction techniques that downregulate the stress response system may work partly by reducing inflammation. The gut-brain axis represents yet another dimension of body-mind connection. The gastrointestinal tract contains a vast number of neurons, approximately 100 million, and produces many of the same neurotransmitters found in the brain, including serotonin, dopamine, and GABA. The gut microbiome, the trillions of bacteria living in your intestines, influences this gut nervous system and communicates with the brain through multiple channels. The vagus nerve, immune signaling molecules, and metabolic products produced by the bacteria themselves. Disruption of the gut microbiome, whether through antibiotics, poor diet, stress, or infection, can affect mood and behavior. Studies in animals show that stress alters the composition of the gut microbiome, and that transferring gut bacteria from stressed animals to unstressed ones can transmit stress-related behaviors. In humans, alterations in gut microbiome composition have been associated with depression, anxiety, and autism spectrum disorders. Conversely, improving gut health may support psychological well-being. Probiotic bacteria, beneficial microbes that can be consumed as supplements or in fermented foods, have shown some promise in reducing symptoms of anxiety and depression in preliminary studies. While this research is still in early stages, it points to the deep interconnection between physical health, particularly gut health, and mental health. Sleep is another critical link between body and mind in the healing process. Sleep serves many functions. It consolidates memories, clears metabolic waste from the brain, regulates hormones, and supports immune function. Crucially, for our purposes, sleep is essential for both physical and psychological healing. During deep sleep, growth hormone is released, stimulating tissue repair and protein synthesis. Immune function is enhanced during sleep, with increased production of cytokines and more effective activity of immune cells. Studies consistently show that sleep deprivation impairs wound healing and increases susceptibility to infection. People who sleep poorly before receiving a vaccination produce fewer antibodies, indicating compromised immune response. Sleep is equally important for psychological healing. REM sleep, in particular, appears to play a role in processing emotions and consolidating memories. During REM, the brain is highly active and dreaming occurs. Some theories suggest that dreams allow emotional experiences to be reprocessed and integrated with less intense emotional charge. The brain replays emotional events during REM but with reduced noradrenergic activity, allowing the content to be experienced without overwhelming physiological arousal. Sleep disturbance is both a symptom and a perpetuating factor in many psychiatric conditions. Insomnia predicts the development of depression and anxiety disorders. Nightmares are a core symptom of PTSD and maintain the disorder by repeatedly reactivating traumatic memories. Improving sleep through behavioral techniques or medication when necessary often improves psychiatric symptoms and supports the effectiveness of psychotherapy. The body-mind connection means that interventions targeting either the body or the mind can benefit both. Physical exercise improves mood, reduces anxiety, enhances cognitive function, and even promotes neuroplasticity. Psychotherapy reduces physical symptoms of stress, lowers blood pressure, and may improve immune function. Mindfulness meditation affects both brain activity and markers of inflammation. Treating depression with medication or therapy can improve outcomes in patients with cardiac disease. Recognizing these connections encourages a more holistic approach to healing, one that addresses the whole person rather than treating body and mind as separate domains. It also provides multiple entry points for intervention. When direct psychological treatment of trauma is too overwhelming, starting with physical interventions, improving sleep, adding exercise, addressing nutrition, can begin to shift the system in a healthier direction, creating a foundation from which deeper psychological work becomes possible. Healing, whether physical or psychological, is never purely one or the other. It is always a whole organism process, engaging all dimensions of human experience. Understanding this can help both in seeking treatment and in cultivating patience with the healing process. When recovery seems slow, it can be helpful to remember that multiple systems are involved, each working at its own pace, each influencing the others, all gradually moving toward restoration and integration. Tools and techniques for healing. Given the complex, multidimensional nature of healing, it follows that there are many paths toward recovery and many tools that can support the process. Some are medical interventions, prescribed and monitored by healthcare providers. Others are lifestyle practices that anyone can incorporate. Still, others involve interpersonal connection and community support. No single approach works for everyone, but understanding the range of options allows individuals to find the combination that best supports their particular healing journey. Mindfulness and meditation practices have gained substantial scientific support as tools for both physical and psychological healing. Mindfulness means paying attention to present moment experience with an attitude of openness and non-judgment. It can be practiced formally, through seated meditation, or informally, by bringing mindful awareness to everyday activities like eating, walking, or washing dishes. The practice seems simple but proves surprisingly difficult. The mind habitually wanders, planning the future, rehashing the past, judging experience. Mindfulness gently redirects attention back to the present, again and again, building the mental muscle of sustained attention and present moment awareness. Over time, this practice changes both brain structure and function. Research shows that regular mindfulness meditation increases gray matter density in the prefrontal cortex and hippocampus, regions involved in attention, emotion regulation, and memory. It reduces activity in the amygdala, lowering baseline anxiety and reactivity to stress. It increases connectivity between the prefrontal cortex and the amygdala, strengthening top-down emotion regulation. It alters activity in the default mode network, a set of brain regions active during rest and mind wandering in ways that reduce rumination. These neural changes translate into practical benefits. Mindfulness-based interventions reduce symptoms of anxiety and depression. They improve attention and cognitive function. They enhance immune response and reduce markers of inflammation. They lower blood pressure and improve outcomes in patients with chronic pain. In the context of trauma, mindfulness-based approaches help individuals develop a different relationship with intrusive memories and difficult emotions, reducing their impact. Physical exercise is another powerful tool for healing. The benefits of exercise for physical health are well established. It strengthens the cardiovascular system, builds muscle and bone density, improves metabolic health, and reduces risk of numerous chronic diseases. But exercise also profoundly affects the brain and mental health. During exercise, the brain releases endorphins, natural opioids that create feelings of well-being and can reduce pain. Exercise increases production of brain-derived neurotrophic factor, or BDNF, a protein that promotes neuroplasticity, supports the survival of existing neurons, and encourages the growth of new neurons and synapses. Regular exercise increases hippocampal volume, the opposite of what occurs with chronic stress. Multiple studies demonstrate that exercise is an effective treatment for depression, with effect sizes comparable to antidepressant medication. It reduces anxiety, improves sleep quality, enhances self-esteem, and provides a sense of mastery and accomplishment. For trauma survivors, exercise can be particularly helpful in releasing physical tension held in the body and in rebuilding a sense of agency and bodily autonomy. The type of exercise matters less than consistency. Aerobic exercise like running, swimming, or cycling provides cardiovascular benefits and strongly influences mood. Resistance training builds strength and also improves mental health. Yoga combines physical movement with breathwork and mindfulness, offering multiple pathways to healing. Even gentle activities like walking can be beneficial, especially when done outdoors in natural settings, which provides additional psychological benefits. Social connection and support are essential for healing. Humans are social animals, and isolation is deeply harmful to health. Strong social connections are associated with lower mortality risk, better immune function, faster recovery from illness, and reduced risk of depression and anxiety. Conversely, loneliness and social isolation are risk factors for numerous physical and mental health problems. For trauma survivors, rebuilding social connections can be challenging. Trauma often damages trust, creates shame, and leads to withdrawal. Yet connection is crucial to recovery. Support groups provide one avenue. Gathering with others who have had similar experiences, sharing stories, offering mutual support. These groups reduce isolation and normalize the struggles of recovery. Individual relationships matter as well. Friends and family who can listen without judgment, who can tolerate hearing about difficult experiences, who can provide practical help, and who can simply be present. These relationships are healing in themselves. They activate neural systems involved in safety and bonding, releasing oxytocin and other neurochemicals that counteract the effects of trauma and chronic stress. For those without strong existing social networks, building connection may need to be a deliberate practice. This might involve joining clubs or groups based on interests, volunteering, participating in religious or spiritual communities, or working with a therapist who can provide a consistent, supportive relationship, while other connections are being developed. Nutrition receives less attention in discussions of psychological healing than it deserves. What you eat affects brain function, mood, and even the structure of neural tissue. The brain is metabolically expensive, requiring a substantial proportion of the body's energy, even though it represents only about 2% of body weight. It also requires specific nutrients to synthesize neurotransmitters, maintain cell membranes, and protect against oxidative stress. Omega-3 fatty acids, found in fatty fish, flax seeds, and walnuts, are structural components of neural cell membranes and influence neurotransmitter function. Low omega-3 levels are associated with increased risk of depression and cognitive decline. Supplementation with omega-3s shows some benefit for mood disorders, though it is not a substitute for standard treatments. B vitamins, particularly folate, B6, and B12, are involved in neurotransmitter synthesis and in the metabolism of homocysteine, an amino acid that, at elevated levels, is associated with depression and cognitive impairment. Deficiencies in these vitamins can contribute to mood problems and impaired cognitive function. Amino acids from dietary protein are the building blocks of neurotransmitters. Tryptophan is needed to produce serotonin. Tyrosine is needed for dopamine and norepinephrine. Inadequate protein intake can limit neurotransmitter production, affecting mood and cognitive function. The gut microbiome's role in mental health, mentioned earlier, means that diet affects mood partly through its effects on gut bacteria. Prebiotic fibers, found in vegetables, fruits, and whole grains, feed beneficial gut bacteria. Probiotic foods like yogurt, kefir, sauerkraut, and kimchi introduce beneficial bacteria. A diet high in processed foods, sugar, and unhealthy fats may promote inflammation and adversely affect the microbiome, while a diet rich in whole foods, fiber, and healthy fats supports gut health and, indirectly, mental health. This is not to say that diet alone can treat psychological conditions or that poor diet is responsible for mental illness. But nutrition is one of many factors that influence mental health, and optimizing it can support the healing process. For individuals who are already struggling, addressing basic nutrition, eating regularly, staying hydrated, including sources of protein and healthy fats, can provide a foundation that makes other interventions more effective. Creative expression offers another pathway to healing. Art, music, writing, dance. These activities engage different neural systems than talk therapy and can access emotional material that is difficult to verbalize. Creating art can provide a sense of mastery and agency, particularly important for trauma survivors who have experienced helplessness. It can externalize internal experiences, making them more manageable. It can facilitate emotional processing and provide meaning and purpose. Art therapy and music therapy are established therapeutic modalities, practiced by trained professionals who guide the use of creative expression for healing. But informal creative practices can also be beneficial. Journaling about traumatic experiences has been shown in multiple studies to improve both psychological and physical health. Even brief writing sessions, repeated over several days, can reduce symptoms of depression and anxiety, improve immune function, and lead to better health outcomes over the following months. The mechanism likely involves the organization and integration of traumatic memories. Writing creates a narrative structure, helping to make sense of fragmented experiences. It allows emotions to be expressed and examined. It creates some distance from the experience. The events are on the page rather than overwhelming consciousness. This mirrors some of the goals of formal psychotherapy, but can be done independently, though it is not a replacement for professional treatment when that is needed. These various tools, mindfulness, exercise, social connection, nutrition, creative expression, along with professional therapies like CBT, EMDR, and medication when appropriate, are not mutually exclusive. Most people benefit from a combination of approaches. The specific combination that works best will vary depending on individual circumstances, preferences, and needs. What remains constant is that healing is active, not passive. It requires engagement, practice, and often courage. But the capacity for healing is inherent, and these tools help to activate and support that innate capacity. The timeline of healing. One of the most common questions people ask about healing is, how long will it take? Whether recovering from a physical injury or processing psychological trauma, people want to know when they will feel better, when the pain will subside, when life will return to normal. The answer, frustratingly, is that it depends on many factors, and that healing timelines vary enormously between individuals and between different types of injuries or traumas. For physical wounds, we can provide some general guidelines. A small cut typically heals within 1 to 2 weeks. The inflammatory phase lasts a few days, proliferation a week or two, and by 2 weeks, the wound is usually closed and covered with new epithelium. But the healing is not complete. The scar continues to mature and remodel for many months afterward. By 6 months, the scar has achieved much of its final strength and appearance, though subtle changes may continue for up to 2 years. Larger wounds take longer. A deep wound that requires sutures might take 3 to 4 weeks for the edges to seal completely, and the underlying tissue may take months to regain strength. A surgical incision typically heals in a similar time frame, with sutures or staples removed after 1 to 2 weeks once the edges have sealed, but with the internal tissues continuing to remodel for months afterward. Fractures have their own timeline. Bone healing occurs in several stages, starting with the formation of a blood clot at the fracture site, progressing to formation of a soft callus of cartilage and fibrous tissue, then to a hard callus as bone begins to mineralize, and finally to remodeling where the bone is reshaped to its normal architecture. Simple fractures in healthy adults typically take 6 to 8 weeks to heal sufficiently that the bone can bear weight, but complete remodeling takes many months. More severe fractures or fractures in bones with poor blood supply can take much longer. Several factors influence how quickly physical injuries heal. Age is significant. Children and young adults generally heal faster than older adults. Nutritional status matters. Adequate protein, vitamins, and minerals are essential. Blood supply to the injured area is crucial. Tissues with good perfusion heal faster than those with compromised blood flow. Infection dramatically slows healing, and can prevent wounds from closing. Chronic conditions like diabetes impair healing through multiple mechanisms. Even psychological stress affects physical healing, as discussed earlier. The timeline for psychological healing is even more variable and less predictable. Some people recover from traumatic events relatively quickly, experiencing acute stress reactions that resolve within weeks. Others develop PTSD, with symptoms that persist for months, years, or even decades if untreated. The factors that influence psychological healing are complex and not fully understood. Severity and duration of the trauma matter. A single traumatic event, while certainly significant, is generally easier to recover from than repeated or prolonged trauma. Childhood trauma, occurring during periods of rapid brain development, often has more persistent effects than trauma experienced in adulthood. Trauma that involves betrayal by trusted others, such as abuse by a caregiver, tends to be particularly damaging and difficult to heal from. Social support strongly influences recovery. People with strong support networks, people who can talk about their experiences and receive validation and care, tend to recover more quickly than those who face trauma alone or in isolation. Conversely, lack of support, social stigma, and victim blaming can significantly impede healing. Pre-existing mental health conditions or prior trauma can make recovery from new trauma more difficult. Each traumatic experience can sensitize the stress response system, making subsequent traumas more likely to cause lasting problems. On the other hand, individuals with good baseline mental health, strong coping skills, and a history of successfully navigating challenges may demonstrate greater resilience. Access to treatment matters enormously. Evidence-based therapies can significantly accelerate psychological healing and improve outcomes. But many people lack access to quality mental health care, whether due to cost, availability, stigma, or other barriers. Without treatment, some individuals may struggle for years with symptoms that could be significantly improved with appropriate therapy. Even with treatment, psychological healing typically takes time. A course of trauma-focused therapy might last several months, with weekly sessions. Symptom improvement may be gradual, with setbacks along the way. Some symptoms resolve quickly, while others persist. Complete resolution of all symptoms is not always achievable, but significant improvement and return to meaningful functioning often is. It is important to distinguish between symptomatic improvement and complete healing. Physical wounds may close and look healed on the surface while the underlying tissue is still reorganizing and strengthening. Similarly, psychological symptoms may improve substantially, while deeper work of integration and growth continues. Healing is not a binary state, healed or not healed, but a continuum of gradual change. The concept of post-traumatic growth recognizes that trauma, while undeniably harmful, can sometimes lead to positive changes. People who have faced severe adversity sometimes report increased appreciation for life, deeper relationships, greater personal strength, new possibilities, and spiritual or philosophical growth. This is not to romanticize trauma or suggest that suffering is necessary for growth. It is not. But it acknowledges that healing can involve more than returning to baseline. It can include the development of new capacities and perspectives that were forged in the struggle with adversity. Understanding that healing takes time, that setbacks are normal, that progress may be uneven, can help maintain realistic expectations and prevent discouragement. The impulse to rush healing, to force things back to normal quickly, is understandable but often counterproductive. Healing has its own pace, governed by complex biological and psychological processes that cannot be hurried beyond certain limits. This does not mean passively waiting for healing to happen. As discussed, there are many things individuals can do to support their healing process. But it does mean accepting that some things take time, that patience is part of healing, that the body and mind have their own wisdom about how quickly repair can proceed safely. Trusting the process, even when progress feels slow, is itself an important part of healing. Closing. The endless capacity to heal. As we near the end of this journey through the science of healing, let your breathing deepen once more. Allow your body to settle more fully into rest. You have traveled through layers of complexity, from the molecular dance of growth factors to the grand architecture of neuroplasticity, from the first moments of blood clotting to the years-long maturation of scars, from the hyperactive amygdala of trauma to the gradual restoration of emotional balance. What emerges from all this complexity is a portrait of resilience woven into the very fabric of existence. Your body knows how to heal. This knowledge is not intellectual or conscious. It is cellular, molecular, ancient beyond measure. Every healing wound recapitulates billions of years of evolution. Countless ancestors who survived injury, whose bodies learned and passed on the intricate instructions for repair. The wound healing process, with its precisely orchestrated phases, reveals a biological wisdom that operates far beneath awareness. You do not need to consciously direct platelets to the site of injury, or tell fibroblasts when to produce collagen. These processes unfold automatically, the result of deep programming that has been refined over geological timescales. When you cut yourself, you can trust that the healing response will engage. You can trust that countless cells will coordinate their activities, that chemical signals will flow, that tissue will gradually reconstruct itself. Yet, healing is not merely automatic. It responds to how you treat your body, how you manage stress, how you nourish yourself, whether you rest or push beyond limits. Physical healing is influenced by psychological states, by the chronic activation of stress hormones, by the inflammation driven by unrelenting pressure. Caring for a wound means more than keeping it clean and covered. It means caring for yourself as a whole organism, attending to sleep and nutrition and stress, recognizing that everything connects. The brain's capacity for neuroplasticity offers a parallel message about psychological healing. Trauma changes the brain, yes. It can leave lasting marks on neural circuits, alter patterns of reactivity, reshape how you perceive threat and safety. But the brain that was changed by trauma can change again. New experiences can forge new neural pathways. Therapy can help establish healthier patterns of thinking and feeling. Mindfulness can teach a different relationship with thoughts and emotions. Social connection can reactivate systems of trust and bonding that trauma suppressed. This does not mean healing from trauma is easy or quick. It is often neither. It requires courage to face painful memories, to feel difficult emotions, to challenge beliefs that have provided a sense of safety even as they constrained life. It requires patience as the brain slowly reorganizes, as new patterns gradually become stronger and old patterns gradually weaken. It requires support, whether from therapists, friends, family, or communities of fellow survivors. It requires self-compassion, recognizing that symptoms are not personal failures, but understandable responses to abnormal experiences. Both physical and psychological healing teach the same fundamental lessons about impermanence and transformation. Nothing remains static. Tissue that was damaged becomes tissue that is healing, becomes scar that is maturing. Neural circuits that were trauma reactive become circuits that are being rewired, become circuits that support resilience. The wound that dominated awareness fades into background. The memory that once overwhelmed loses its sharp edges. And through all of this, life continues. You are not merely a wound healing or a trauma being processed. You are a whole person, living a whole life, experiencing joy and beauty and connection even as healing unfolds. Healing does not require putting life on hold. It happens within the flow of life, sometimes quietly in the background, sometimes demanding attention, but always as one thread among many in the larger tapestry of existence. The timeline of healing stretches far beyond what we often acknowledge. Physical wounds continue maturing for months or years. Psychological integration of trauma is an ongoing process, not a fixed endpoint. Healing is not a destination where you arrive and then stop. It is a capacity, always available, always ready to engage when new injuries occur. And injuries will occur. This is part of living. You will cut yourself again. You will face loss and disappointment and pain. But you will also heal again, drawing on the same ancient capacities, the same resilience encoded in cells and circuits. Perhaps the most profound aspect of healing is what it reveals about the relationship between damage and wholeness. A healed wound is not identical to undamaged tissue. A scar marks the place of injury. Neural circuits reorganized after trauma carry traces of what was experienced. Healing does not erase the past or restore a pristine original state. It creates something new, tissue that is functional even if different, a self that has integrated difficult experiences even while being transformed by them. This understanding can shift how we think about healing. The goal is not to return to some previous state, to erase all evidence of what happened. The goal is to move forward, incorporating what has occurred into a larger story of resilience and adaptation. The scar is not a failure of healing, but a mark of healing accomplished. The person who has faced trauma and done the work of recovery is not broken but strengthened in specific ways, even while remaining marked by what was endured. We live in bodies and minds designed for healing. This is cause for gratitude and wonder. When you consider the billions of coordinated cellular events that occur during wound healing, the intricate molecular conversations, the precisely timed phases, the remarkable capacity of tissue to regenerate, it is nothing short of miraculous. When you consider that the brain can reorganize after trauma, that new neural pathways can form, that psychological symptoms can improve and sometimes resolve, this too is extraordinary. You carry this capacity within you. Right now, in this moment, healing is happening. Cells are being replaced. Connections are being refined. The body maintains itself, repairs itself, adapts itself. Even as you rest here, listening to these words, your body is engaged in countless acts of maintenance and restoration. This happens without your conscious effort, but you can support it through how you live, how you care for yourself, how you respond to injury and stress and trauma. As this exploration draws to a close, I hope you carry with you a deeper appreciation for the gift of healing. Not just in dramatic recoveries or complete resolutions, but in the ordinary, ongoing work of repair that sustains life. In the cut that closes, the bruise that fades, the strained muscle that strengthens. In the difficult memory that becomes less intrusive, the anxiety that gradually loosens its grip, the trust that tentatively returns. Healing is patient work. It is humble work, happening mostly beneath notice, in cellular activities too small to perceive and neural changes too subtle to track. But it is also powerful work, capable of closing wounds, mending breaks, reweaving torn tissue and fractured connections. It is work that you can trust, because it is built into your very structure, refined over countless generations, available whenever you need it. If you found peace in this journey through the science of healing, please consider liking this video and subscribing to the Sleepy Science Society. Your support helps others find this quiet space where knowledge becomes a companion to rest. And please, share your thoughts in the comments below. What aspects of healing resonate most with you? What questions linger? For now, let yourself fully settle into rest. Let the knowledge of your body's healing capacity be a comfort as you drift towards sleep. You are resilient. You are designed for repair. You carry within you an ancient wisdom that knows how to transform injury into wholeness, pain into memory, wounds into scars that tell a story of survival and strength. Let your eyes close if they haven't already. Let your body sink into comfort. Let your breathing slow and deepen. The work of healing continues even as you rest, perhaps especially as you rest. You are safe here. You can let go. Good night.